Hello and welcome to the Melbourne Athlete Development Podcast. Today we have Associate Professor Antonio Stecco with us today. Antonio, thank you for being with us.
Well, thank you for the invitation. Always a pleasure.
Just to give some context for the conversation, do you want to give us a background of who you are and what you do?
Well, I'm a medical doctor. I did my fellowship in Rask in Kessler in New York, New Jersey. Then follow up with a PhD between Padua University and New York. And now I'm assistant professor in New York University. I'm mostly dedicated to myofascial pain and whatever is related to fascia from biomechanical point of view and from pain perspective. So this
Hmm.
is like my main topic.
So, what got you interested in fascia and myofascial pain?
It's a long story, but I mean, we say that we have a family that is really related to fascia. So my father, long time ago, started to make research and publication about fascia. My sister, that is orthopedic surgeon, help to get in depth, the fascia as a tissue with a histological study, anatomical study, and I saw result of the treatment that my father was applying to me when I was like a young, player, and so I was really curious to understand how it works, what is the, the etiopathogenesis of this problem that can be resolved with manual therapy, and so this is why I decide to keep going in this topic and go have a better research from imaging point of view, from clinical point of view, to better understand how monotherapy can improve pain.
So, growing up in that environment, and particularly when you started studying medicine, were you like initially skeptical of a lot of the things that your dad did, or were you quite curious and interested to explore more? Like, how did you initially think about it, and how did that evolve over time as you did more research into it yourself?
I mean, of course, I was quite skeptical about, the theory that there were behind at the beginning. Um, but let's say that it has to be metabolized and just make it more simple and more scientific. But
Mm.
all the concept that my father introduced at the end of the day was correct. It's just that it has to be translated in a language that is more understandable from the people, and of course with scientific background
Mm.
behind. So that was very curious because, um, as I said, a lot of manual therapy is it's not really clear what they are doing. And even if you go in depth, it seems still difficult to understand. Uh, in this case, I mean, at the level of the biochemistry, so like at the level of really what changed in the extracellular matrix was still a chimera, was still like in dub, but further study have supported this alteration occur, and so it was a nice match between what we were thought to occur at that level of the biological level and what seems really to happen.
Mm. Yeah, why do you think that is the case? When you talk about manual therapy, it seems to be a topic that is very controversial. I know a lot of people suggest that manual therapy has no value at all. There's obviously some people who speak very against that. Why do you think there seems to be so much differing opinion about whether manual therapy has therapeutic value?
Yeah, this is true. This is like a really global problem. Um, let's say that the major difficulty is to make manual therapy reproducible. So we don't really know exactly what each therapist is doing, and if you can really reproduce the same treatment.
Mm.
So a great advantage of, let's say, fascia manipulation, so this specific manual therapy that we apply, is that we have a codified data that has to be treated. So we have a map with exactly location where we have to assess the body through a palpation and where to treat. So this allow us to publish a nice article that explain that the ICC, So the interoperability test, even students that have just done the course, was very high. Why is that? Way higher than trigger point therapy or other therapy. Why is that? Because it was requested to the student to rate the alteration in the specific spot that they have learned. So there was no bias in the where you are assessing the patient. The patient was assessed in the same location because this is what the technique is telling you. There was a slightly difference in the rate. So we rate 1, 2, 3 as a amount of alteration in that area that is considered like a rough surface, rigid and compressible. So between students, maybe someone was giving 2, someone is giving 3. So there was a slightly difference. But it was really clear when there was an alteration, where it was not altered. That was a really impressive, the consistency of the result between students. In the ICC, like the intra and the interoperability was like a more than zero point 0.8, between 0.8 and 0.9 in relation of what kind of analysis we have done. So way more than the normal, reliability test that you have in manual therapy that is pretty bad. Is like a zero point 0.5, even less sometimes. So that was a greater article that it was even curious for the reviewer, because the reviewer said, look, how is possible that monotherapy can have such high interoperability test? And we have to explain in detail that this method tell you where you have to palpate. This is a
Mm.
big plus to make more objective. And also, a lot of publications that we have done, um, it were nicely accepted by a reviewer, because it's playing, look, this is the map. We have treated some of this point that you see in the map. We applied a mean time of 3 minutes and a half deep friction manipulation over the spot until we feel the tissue glide better. At the same time, the patient feel less than half of the pain. So this is quite consistent. This is kind of a reproducible experiment.
Mm.
So that is why we were able to, you know, publish many articles about manual therapy, probably because the way that we explain the process of analysis and treatment is quite consistent, is reproducible.
Mm. I think the thing that you highlight there too, that I think back to when I was studying physiotherapy, that we didn't learn anything about is actually what you're feeling, those qualitative aspects of what you can actually feel in the tissue with your hand. When we think about the deep fascia network, one thing that we need to consider is that sliding. Would you be able to describe the sliding system and what that is, and what actual mechanical role that provides for the musculoskeletal or myofascial system?
So we are used to see like a MRI picture, CT scan, even picture of ultrasound. But if you try to do dynamic ultrasound, you see how each structure move.
Mm,
In order to move, you have to have an interface made by two layer fascia with loose connective tissue in the middle. So each area in majority of the structure need an interface. Between bone and muscle, you need an interface. Between vessel and muscle, you need an interface. Between a nerve and muscle, you need an interface. So each structure need a different motility. Between each organ, you need an interface. So who is generate the interface? Two fascial layer in the extracellular matrix between. So we will see in our body, with dynamic ultrasound in particular, that each structure is moving, and the movement is the function. Mobility and motility is the function of the organ, of the of the muscle. So this required a really sophisticated infrastructure to allow each structure to move kind of independently without irritate the neighbor area, because we don't want to irritate the nerve at its own side. We don't want to compress the vessel at its own side. So the fascia system have this role, and on top of that, the fascia system have the role to transmit far away the traction, the contraction of the muscle. So the fascia system can become like a large flat tendon that can transmit the force far away. And that, of course, will be a great advantage for us because you will bypass the joint, so you will decrease the stress in the joint. You increase the lever of each muscle because the arm of the power will be much longer. So there is an endless number of advantage to have such sophisticated fascia system. And this you will see in all the animals that have a sophisticated motion, like a high-speed animal. So if you do a dissection in a chicken, it will be very sad to see that the fascia system is really poor.
Mm.
But if you do a dissection in a rabbit, it's amazing how fascia system is so well developed. It's beautiful. It's a really amazing the morphology of the fascia system. So that is why we need this infrastructure because we have like a relative complex motion to do. We have also torsion, and the torsion is not the typical movement of majority of the animal. So that required a pretty complex fascia system.
Yeah, a few questions come from that, but just on that point, if we look at the human fascial system compared to another mammal, do we see specific differences that can help explain some of the more complex movements that we can create?
Yes, like the major difference is the collagen fiber in oblique direction.
Mm,
So it's really particular. I don't want to say unique, but it's quite particular to have collagen fiber in oblique direction that will work a lot for torsion. So like a running, that is a huge, you know, effort for our body, required a torsion of the trunk.
mm,
So uh, even when you walk, it's easier for you to move the arm rather than not move. If you run, it will be really a challenge to run without move the arm. So fascia systems transmit the load from the inferior limbs to the trunk to the upper limbs. So that means that whenever you run, whenever you walk, there is load transmission coming up. And so this load transmission has to be dissipated in the upper part of the body. At the same time, these mechanics will help to balance the weight in the running process. So uh, differently from other animal, this collagen fiber will allow us to as a bipedal to run properly in a perfect mechanics in like in an economical way, because in this way is more economical than lock different part of the body. So
mm,
there is a lot of knowledge about this that has to be interpreted properly. And let's say that the fascia was even there before some muscle. So before to have latissimus, there was already fascia system there. Before to have the large trapezius, in the past there was a small trapezius and fascia layer. So this flat mass in the trunk developed inside a bilamination of the fascia to work with isometric contraction to connect the different limbs, or alone to permit the independence of different limbs. So study the evolution is really help to understand why fascia is in such uh, morphology right now.
mm. When we talk about fascia, we're referring here specifically to the deep fascia, so the muscular fascia and also the aponeurotic fascia. When I think back to again being at university, and I'm sure you probably had this experience yourself, Antonio, anatomists will remove the aponeurotic fascia of the arms and the legs, and also things like, well, not necessarily always, but potentially like the thoracolumbar fascia and the rectus abdominis aponeurosis. Why is this the case? Why do they remove the aponeurotic fascia? And what implications do you think that has for how we view anatomy in the human body?
Okay, this is very important. So this is like a bias that they have developed over the year. So if we talk about I mean, I study in Padova. In Padova, we have Vesalius. Vesalius wrote the first atlas of anatomy in the world.
Mm,
So
mm,
since then, not much has changed. since 40th century, not much changed. Because if you see all the review of Atlas, is just like a small update of what was before, but nobody went against like the lowly books of this great anatomist in the past.
Mhm.
So the anatomists at the beginning, they want to show better the organ, the muscle, okay, that was like the really thought the key element of the anatomy. And so of course you have to remove the fascia, but in some area the fascia was so thick that it was not even possible to decide to avoid to represent in their atlas, because the IT band is so thick, so important that how you can take it off, because even someone else that do a dissection will say, look, what, we miss a piece right here. uh, the bicep neurosis is so thick, is so important that you have to preserve there. So now we have this anatomy that is a little bit silly, because you Google bicep neurosis, it will come up with this structure. So everybody knows that it's there. But if you ask everybody why it's there, nobody is able to answer. Because they leave like this piece of fascia over there without represent all the continuity that there is. They leave the IT band, but in reality, they have to sacrifice the majority of the part of the IT band, because the IT band is not like a tendon, but is like a reinforcement of the fascia lata. So this was like you know, a a strategy to try to represent the muscle in the best way as possible. Take it off like what is between, what is above the muscle. So it's a limitation that was necessary at that time, and then was never fixed. But at the same time, I want to underline that in Padova we have books of 17th century, 18th century that is fully dedicated to fascia. We have like a um, we have like a different book about scarpa, for instance, that discover like the scarpa fascia, the import of the fascia for herniation. Okay, um, we have a Sturzi that it was a kind of orthopedic plastic surgeon of the 18th century that wrote a full books about the superficial fascia. So there are this information, and we have collect this information, because the great advantage that we have when we start to write down books and articles is to get this amazing library with such old books where fascia is well described. But unfortunately, probably for language barrier, I mean, they were never translated in English, they were never spread out. And so this knowledge are, preserved and conserved in these old books. And I mean, and then medicine went to, chemistry and other, topic. And then they say just anatomy is over. Okay, there's nothing else that to be discovered. Uh, it's not really true. We are trying to promote the rule of fascia in biomechanics, in neurophysiology as well. And I mean, the hard job that we are doing is to explain that the fascia is extremely well innervated. So it's more innervated than tendon and ligament. So it's definitely more a pain generator than that this tissue. They have a equal innervation of the muscle. A muscle have a large nerve with a motor fiber. Fascia have a lot of free nerve endings. So at the end of the day, fascia can be a better, can generate much more afference rather than the muscle, because muscle have just a lot of large nerve, fascia have a lot of free nerve endings. So fascia become one of the tissue that can generate much more afference than, of course, tendon and ligament, and probably also muscle.
I think we come to that in a moment because it's very important for a number of topics related to sensory motor output and sensory motor control. But I'm very interested in the history of particularly your family and the fact that was there a reason that your father in particular decided, okay, we have this knowledge in Padova. I want to explore this and I want to actually start moving this fascial research forward?
Well, my father was in the first class of physiotherapy ever in Italy. So they were in four.
That's a good fact.
Yeah, so they were in four. Even them, they didn't know exactly what physiotherapy was.
Hmm.
And when they, I mean, they have all the library to study for sure, but when they finish up, nobody know what a physiotherapist is. In the hospital, basically, there was an orthopedic surgeon, and damn it, they didn't know if it was doctor, what kind of, healthcare practitioner they were. So they have a great possibility to try to see different manuality, to study in the library, because I mean there was not so much student at the time. So that was two components. So like the ability to practice and to have the freedom to try whatever seems works better, because you can imagine what was like the way that they were teaching physiotherapy when nobody even know what is physiotherapy. Okay, so they had the rule to take care of the patient, but they don't have like a proper guideline tool to do that. So they were forced to try whatever worked. Okay, they were, because I mean they have no option, no background behind. And so you have a library that tell you about this structure. You see that manual therapy in some way was working. You just have to explain why it worked. Okay, what could be the rationality behind. And lucky for us, I mean, there's all this book that talk about fascia. Okay, so in the past there is more citation about fascia than now. That was curiosity, because look, come on, I mean, they were talk about fascia. Is there, it could explain transmission, referring pain that nerves cannot. Muscle is too short to explain this such a long referring pain. So I mean, this can really be like what explain this pulling tension, this like a rigidity, this stiffness. That, I mean, patient will perform, like will refer to the therapist. They say, look, I feel rigid. I feel like a cast right here. I feel like a pulling all over my arm. Okay, so I mean, watch this atlas and see the clinical, symptom of our patient. There was like a, of course, it come up in your mind that maybe that can be an explanation for that. And then there was a long story to try to prove it, try to organize not just the anatomy of fascia. It was a really challenge, because all these test book, there's a small citation right here, a small citation right there. Each atlas, each anatomist gave their own name to the fascia. Let's say scarpa fascia, fascia of Camper, fascia of Collins. So that was a mess. So just to try to organize and classify the fascia system. And when you talk about visceral fascia, even worse the situation.
Hmm.
So I mean, the first milestone project was to organize the classification of the fascia: superficial fascia, deep fascia. Deep fascia can be aponeurotic, epimysial. Visceral fascia, we call like investing fascia, insertional fascia, to try to clarify. And then from there, you start to understand the biomechanics, so the histology of this tissue. And that was another challenge, because there is a different morphology of the fascia. And then you start to work with the innervation, and then there is a different innervation of fascia. There is free nerve endings. There is a ruffinical corpuscle, pacinic corpuscle. And then you will start to study the pathology of the fascia, so the loose connective tissue, how that can change, rather than kind of fibrosis that is really difficult to have. You have only with infection, with surgery, with trauma. Okay, with the radiotherapy, you will have fibrosis. Most of the time, you will have an exchange of the loose connective tissue, so like the interface between fascial layer. And that was another milestone project to understand that. We are still working to get more robust data on that. So you see, it's a long way. So now we are in a better place. We are pretty satisfied where we are right now, but the process was really long, and it need a lot of effort to move forward. You can
Well,
imagine.
yeah, well, that I think is interesting too. Was it always the case that, say, yourself and your sister were going to take on that research, or did your dad have to, push you into it? Because it has become a family affair, and the Stecco family now, I think, is extremely well associated with fascial research and pushing the development of this area of anatomy. But was that something that was always going to happen, or was your dad, very forceful in saying, "I've got more work to do and I need your help"?
Uh, Not really sure with my sister what happened with my sister. Personally, I mean, I don't want to say I was an athlete, but I was doing sport quite intense. So uh, my father was keeping fixing me, okay, minor stuff, but still, bad on you if you do athletes, like pulling, tension, pain. So at the end of the day, during medicine, my mama forbidden my father to talk about fascia because it just make confusion to him. Don't say anything to him. So I finish up medicine, and then I have to choose a residency. So I was able to enter in orthopedic surgery and physical medicine rehab. My sister was already an orthopedic surgeon, and of course, look, rehab can be interesting, but I mean, you have to have a topic. You have to specialize yourself. I mean, you have to, you know, use this time at the best. Okay, so uh, I went in. I really see that the actually guideline was really poor. The rate of success was very poor. So it was really a pity to see this patient that they don't really get better or not as fast as in the other specialty. Okay, so cardiology, you give a pill, it get better. If it doesn't get better, you change pill, and it will get better. Okay, in rehab, you did like a physical therapy, not get better. You give another one, it doesn't get better, and you try the third one, it can happen the third one doesn't get better. So that is like a super frustrating for you. It is really, I mean, it's a nightmare. Okay, because you look what I'm doing, what I study, if it's not working one and two, I mean, are you doing random treatment to this patient? All right. So that was a really a big push for me. So look, let me go back. Let me go back to Department of Anatomy because that time my sister was already there. So let's try to study from scratch what exactly could be the alteration. And I mean, a lot of like a big puzzle start to make sense because you will see that fascia can give you an answer for a lot of questions. First of all, referring pain. There is no innervation, no distribution of root that can really explain such a variability within the same subject, because over time radiation can change in a same subject. So only fascia can have like this change in stiffness due to a lot of variable temperature, humidity, immobility can really affect, increase the viscosity of the extracellular matrix. So that can explain why on day one the patient have a pulling that go up to the shoulder, and on day two the pulling go in the neck. Okay, and the pain go in the neck. This cannot be explained by neurological point of view. So there's too much variability. Okay, if this person have done a garden and then the day after is reading a books because it was tired, where there is more overuse, it can generate like a more isometric contraction. It can increase the viscosity, increase the stiffness. So you can have a daily different kind of pulling, spreading pain due to this alteration of the extracellular matrix. So fascia can explain why you have such rigidity, stiffness, because sometimes it's just a question of stiffness, not really pain. And fascia can clearly explain, because fascia is like three long socks in the leg, three long gloves in the arm, with loose connective tissue in between. Imagine if this loose connective tissue become viscous like honey. It will dramatically affect the mobility of the arm. It can become almost like a cast. So this can easily explain a lot of symptoms of the patient that normal, like a traditional medicine was not able to explain. So there is so many answers can be given by the fascia system that it start to make perfect sense the picture that you are in front of you, and give you so much satisfaction that you are forced to keep going, to keep doing research, because each discover is like the possibility to make better one patient. So I mean, it becomes the scope of your life, because it is just the only way that you are seeing right now to daily improve your practice and improve the patient that you are treating.
And so, just you describing then referral or myofascial referral pain, this is obviously different to say the Travell and Simons model, where their description of referral pain is more neurally mediated. From what I understand, it's got to do with signals being sent to the spine and interneurons sending then pain signal to another nerve segment, so to speak. But because of the fact that we see so much variability in where pain is referred, it doesn't really seem to be explained then from the nervous system, because the nervous system is very consistent in terms of its actual layout within the musculoskeletal system, as opposed to this particular model where fascia potentially pulls is going to vary from person to person based on their history, based on the sport that they've played or the types of activity that they do.
That is perfectly right. So on top of that, I mean, the the fascia, like the loose connective tissue, the viscosity can change for any reason. Like
Mm,
hyaluronic, that is the chief component of the extracellular matrix, it can aggregate. And the aggregation will generate an infrastructure, a 3D infrastructure they call macromolecular crowding, that can be as large as 1 millimeter. So imagine like this big, like a infrastructure of even more than 1 millimeter between two fascial layer. It will make the extracellular matrix extremely rigid, like imagine like a sponge with like a tiny hole that was able to bind water, rather than a sponge with a large hole that is not able to hold water. So of course, the sponge with a tiny hole is a smooth sponge. So it's really the best type of extracellular matrix that you want to have. The
mhm,
sponge with a large hole, it's still a sponge. It can still have the same water on side, but doesn't hold the water. It's not an homogeneous lubricant at all. So this is what happens in your extracellular matrix. So you can have these two kind of extracellular matrix. These can be triggered by many different stuff. So like a low temperature will increase the viscosity. Low pH will increase the viscosity. Immobility, because hyaluron have a thixotropic effect, can increase the viscosity. So it's enough to just sleep during the night. You wake up in the morning, the first three steps, you feel a heel pain or leg pain, and then it go away. That is not arthritis. That is myofascial pain due to the thixotropic effect of hyaluronate. It's like ketchup.
mm,
You shake it, become fluid. You leave it, become sticky. It's exactly the same. Okay, so you stand up from the chair after a couple hours of dinner and you feel like a knee pain. That is not arthritis. That is myofascial problem. There is a drop change of the temperature. It's going to rain like a storm, and you start to have neck pain. That is not arthritis. That is myofascial pain, because low temperature increase the viscosity, high temperature decrease the viscosity. So worldwide, when the patient is telling you, look, the doctor told me that I'm inflamed, I have to put ice, but don't say to anybody, I had a hot shower and feel way better. Okay, so when the patient tell you, look, I put the heat in that area, yeah, I feel better, cannot be inflammation, because inflammation with heat will make it even worse, because it will increase the inflammation. So whenever the patient tell you, look, heat is making better, it has to be myofascial pain. Have nothing to do to real inflammation. Okay, and this is a endless number of patients that will tell you that the heat make better than cold. So this is another important topic. So let's be sure when we talk about the inflammation. Okay, because a lot of time there's this big problem. The general practitioner tell you they are inflamed. You take an anti-inflammatory, you have a good response, you think that you are inflamed. But that's not true, because the anti-inflammatory, it works for a huge number of symptoms, even myofascial pain. So there is this misunderstanding in a lot of patients. They really believe to be inflamed only because anti-inflammatory respond well. But then if we ask, do you prefer ice or heat? They will tell you that the heat works better for him. So this is probably or almost sure myofascial pain that you make better. pH, if you drop the pH in the muscle, you can get easily through 6.7. Low pH will increase the viscosity of 25%. So everybody have experienced, if they have done like a half marathon, that at the end they feel like stiff in the leg. And that stiffness remain for a couple hours or even more, and then go away. But if you have like a, you know, a ultra marathon, you do the half marathon and just walk away easily, nicely, smoothly. Why is that? Because in relation to how much lactic acid you produce, you drop the pH in the muscle and you increase the viscosity. So even if you go in the gym and you lift like 100 times, some weight, you can feel rigidity due to the lactic acid. But again, lactic acid is not enough. Is the aggregation of hyaluronan pushed by low pH that explain the stiffness. Then normally everything go back as it was, but in some place, maybe before a deficit of drainage or other reason, the stiffness, like the high viscosity remain, and so the patient will start to have myofascial pain in that area due to overuse.
And
So
so I was just going to say then, Antonio, so when we think about myofascial pain, the reason why we get it is because that gliding that should occur between those deep fascial interfaces is lost. And when we do that, we get an increase in essentially mechanical tension, which causes those free nerve endings to send a nociceptive signal. Is that correct?
yeah, that is correct. So at the same time, you can have two symptoms like rigidity and peripheral like a sensitization, peripheral bombardment, because you basically irritate it. You decrease the threshold of the receptor, because you have this receptor, this free nerve endings in a stiff environment, so they will be constantly irritated or stimulated. uh, I want to add something more. Even ticklish, it can be a sign of increase of the stiffness in that area. And you will see amazing that you treat the patient, say, look, come on, the first time in my life that I can touch myself, I don't feel ticklish. So it's just a different level of stiffness. Okay. So ticklish, itching, and then way low pain, it can be a different, stimulation of free nerve endings in an incorrect environment. So the stiffness of the environment will modulate the activation of free nerve endings. And there is literature about that. There is the polymodalic receptor. There is the tissue viscosity shape the dynamic response of the receptor. So there's literature about that. And of course, clinical experience will confirm all of that.
When we think about pathophysiologicals within the deep fascia, can we use that knowledge to help explain what a trigger point is?
All right, so I have a nice slide in my presentation. I try to compare what we have right now worldwide about, alteration with ultrasound in non-specific pain. So trigger point was defined as an hypoechogenic area that is more stiff, tight bundle, more stiff. But what is an hypoechogenic area? So an area that is more fluid. But what is this fluid inside the trigger point? Can be blood? I don't think so. Can be lymph? I don't think so. But it can be a hyaluronan aggregate. It is a fluid, but is more stiff than the surrounding area. So far in literature, who was able to see a trigger point have majority of the article, like a 6/7, was a hypoechogenic area. So that can be a what we call densification, aggregation of hyaluronan that will increase dramatically the viscosity. So the perimysium, because the majority of the time a trigger point was seen in the trapezius area. So in that area, we have an epimysial fascia that is made by two layers with perimysium that goes side to side. So you have like a small container right there. So if inside this small container you have a fluid that is more viscous, all the container can become rigid. And so you can start to have like this tight bundle that nobody so far was really able to explain where it's coming from. So there is a pretty good correlation because I want to say that trigger point can is like an increase of viscosity, but when the situation can become chronic, this alteration will affect all the fascia above and below, and this rigidity will affect the surrounding area. So you start to have a trigger point that is spreading the pain, and that will start to generate a biomechanical problem distally and proximally. So you start to develop compensation in a neighbor area. And so the patient will start to complain not just the pain in the upper neck, upper trap, but will start to have pain in the shoulder, in the neck. In the fascia will be like the driver that will, or the structure that will transmit this stiffness in surrounding area. And then this stiffness will require the overuse of the opposites, muscle and fascia to try to balance, to keep straight the patient, the head of the patient. And that overuse will generate other increase of viscosity. And so you build up densification, increase of viscosity in different parts of the body. And that make a more chronic, more severe, the syndrome of the patient. Uh, on top of that, Elena Langevin published an article about chronic low back pain. And she found out that the thoracolumbar fascia is 25% thicker and 52% less gliding, so more stiff. My article about neck pain, I find out that in the neck, the fascia in chronic neck pain is thicker with more black in the middle. So you can see that everybody is finding the same result. Trigger point is black. The fascia in the middle is more black because there is more interface between layers. Trigger point is more stiff. Thoracolumbar fascia is more rigid, less gliding. Thoracolumbar fascia is more thicker, and the fascia in the neck, in chronic neck pain, is thicker. So from different perspective, everybody worldwide is finding the same result. The only problem is that everybody is looking from their perspective. So, the people from trigger point, they didn't check the fascia around. But when I see that ultrasound, I don't see a normal fascia around. I went back, I look the muscle, the external end of the SCM, where I evaluate, like in the scalenus, where I evaluate the fascia. It is true, the muscle below it seems more black, but I didn't collect data of that. So it can be that you have a trigger point, fascia alteration, and then this fascia will, generate compensation far away. This is what looks really like. But of course, more study has to be done.
You mentioned biomechanics and how it can cause alterations across different areas of the body. Currently, a lot of the biomechanical research is very much more mechanical than it does necessarily take on the biological component. Are we seeing enough of an integration of this anatomical knowledge, and particularly the knowledge that is developing in fascia, being translated into biomechanical research in relation to movement and capability of potentially changing that over time?
This is a big topic that we are working on. Um, in particular to apply in sport, because
Yeah.
we did a lot of biomechanical study in lab, so with different sample of fascia. So we published a lot of article about that, and we are trying to explain better what is, for instance, warming up. Okay, So what is warming up? Warming up is the way to decrease, to get to the plateau, the viscosity of the extracellular matrix. Because if you don't bring down to a plateau the viscosity, if each time that you perform a motion, the mechanical stress to perform a motion will change the viscosity. So the second time that you repeat the motion, the viscosity can be slightly less. And the afference and the way that the body responds to that load can change slightly. So to perform in a safety situation, you have to reach a plateau where whenever you move, the viscosity will not change. So we prove with some study that that is the really target of the warming up. And the warming up should be different between athletes and athletes. So there is already a huge revolution can be done in relation of this knowledge. On top of that, stretching. Are you really stretch the muscle or are you stretching the fascia? Because the muscle is in series with the tendon. Fascia is in parallel with the tendon and muscle. Muscle can be elongated between like a 60 and 90% of its length. Tendon less than 4%. But the tendon is in series with the muscle. And the fascia can be elongated no more than 20%. So when you stretch, what you really stop you is not the muscle, if you do a passive stretching, of course, but is the fascia the first element that will stop you.
Mm.
Okay?
I was just going to say, like, John is actually a sprint coach as well. So he works a lot with running athletes. And I think the thing that's interesting to consider too is you mentioned before collagen being obliquely oriented in humans. And thinking about the implications that has for movement, like for instance, describe trunk rotation. I think it's interesting though to think about, say, with running as well, where a lot of elite runners, their movement is not purely in a sagittal plane, even though they actually need to move just forward. You see a lot of rotational components to that. And it seems to make sense that when you describe the deep fascia having a lot of oblique fibers, is that actually a mechanism we use to wind up our fascial system because of its ability to be able to store and release elastic energy?
Yeah, this is a very important topic. So, I mean, I just came back 2 weeks ago from US for spring training. So we are working with half of the baseball team, first league, major league in US. So I was there, I was treating the athletes, and we were seeing the result to speed up the recovery after injury and also to optimize performance. So baseball team, the picture, they really need a perfect biomechanics to get to the best of their throwing. So of course, when you pitch, you use all the infrastructure of the fascial system. So you have to use the power of the leg, of the trunk, of the arm, not just the arm to throwing. So you really have to have a perfect fascial system from the leg to the arm. So in this case, like in a runner, you need oblique fiber because there is torsion. But it's not just that, because it's always a complex motion. So you need to do Trendelenburg, so put the load in one leg, and so you have also the frontal plane that you will use. You have to bend and crunch, so you need also the sagittal plane. So it's always a combination. So you will never use like a isolate some structure. So this is why it's so sophisticated our fascial system. But when it's time to assess and to treat, you will try to decompose, I try to define what kind of plane of motion is more altered, and you will start to treat from that plane, see the result, and then you will start to assess the collagen fiber in another direction and see how altered are that one, and you will start to take care of that. So whenever you move, you use always a combination of different collagen fiber, different muscle. When it's time to assess, you try to simplify the assessment and try to separate one from the other, but just for logistic point of view, because in these athletes you will need like a 2-3 session and take care of each session of structured work, more for sagittal plane, more for frontal plane, more for horizontal plane.
Mm.
So it's just a question of logistic that we can discuss in from in our therapeutic approach with our guideline. But taking consideration that all complex motion need a mix of motor unit and collagen fiber that are in different direction.
I think what's interesting you highlight there is if you, for instance, have changes in the biomechanics of the fascia, that sends feedback to your central nervous system that will regulate how you move. So, one of the things that's interesting too with the fascial network is it has proprioceptors that actually give input to your central nervous system to help coordinate movement, and that we actually see changes based on the quality of the sliding mechanics or the quality of the tissue. And if we see alterations, people actually have quite good capacity to create compensatory patterns, even though that may potentially lead to further issues because you're overloading potentially other areas of the body.
Yeah, we love to say that the fascia is the organ for proprioception.
Mm,
Organ because it's made by dense and loose quantity tissue, free nerve endings. So it's not just a simple tissue; it's an organ. But it's the organ for proprioception because it's the best infrastructure that we have to perceive the motion. It's in the periphery of the body, so have the best momentum. Is all over the body, so it's able to catch each single direction of your body that you are taking. Is relative consistent, the dimension of the fascia. It's not like the muscle gets shorter and is longer. It's quite fixed. You need a relative fixed dimension to perceive the traction and the motion. And on top of that, it's full of free nerve endings. So you don't have anything better than the deep fascia to perceive the motion in the space, to perceive the body in the space. And this is why we really want to say that the fascia is the organ for proprioception if everything works well. If there is something wrong, the same receptor, instead to perceive the body, they are irritated, so generate the pain. So this is why you need a perception in all the direction, in all the three plane. At the same time, you can have pain in all the plane, in all the direction, in all the body, because the same receptor can be used instead to give an afference, a proprioception afference. They can be irritated and generate pain if this infrastructure that's really sophisticated doesn't work properly. Each overuse, each trauma, each immobilization can affect the fascial system, and so can lead to irritation of free nerve endings and so painful afference.
I'm mindful of the time, Antonio, because I know you have to leave shortly. But just to finish up, I was a question we like to ask our guests is there something that you're learning about at the moment, which may be related to your professional work or might be outside of your professional work that's you're very interested in at the moment?
So we are working in neurological patient and as well in athletes. So we are working that two direction. So since 2013, we have developed a new therapeutic approach for spasticity. So we use human recombinant hyaluronidase, so the enzyme that metabolizes hyaluronic acid, to decrease the spasticity in patient. And we really even prove, I want to say, that is not enough for the stroke to generate spasticity, as everybody knows. You need a peripheral implication in order to generate spasticity. And this is generated like a huge success. We are already in phase 2. We have finished phase 2. We are going to start phase 3 to make this drug available worldwide. And that I believe will be a big step forward to manage this patient that really with spasticity will really affect the quality of life. But at the same time, we are transferring this information for sport injury prevention, a sport optimized performance. Because in particular, baseball, tennis, golf, they really understand that they don't have direct trauma. Everything is related to overuse most of the time. So they really need a perfect biomechanics to perform properly and to decrease the severity and the frequency of the injury. We have done a randomized controlled trial in soccer player, and we saw that treating with fascia manipulation this player at the beginning of the season, we dramatically drop the severity, the frequency of ankle sprain. Because remember, in the ankle, we have the retinacula. Retinacula are the key element for proprioception. The amount of free nerve endings is one third, almost double of no other part of the fascia. So the retinacula in the ankle, in the wrist, in the patella are really the key element for proprioception because you really need that.
Mm.
You are a very sophisticated joint, like the tibiostragalic joint, the two line of bone in the wrist. So you need a more accurate proprioception there. This is why you have also the retinacula that is not just there to keep the tendon down, but is there to perceive bone motion because there is insertion in the periosteum, tendon motion because the tendon sheath is a bilamination of the retinacula, muscle motion because it's in connection with the palmaris longus, extensor brevis, abductor pollicis, is full of receptor. So these become the major, the more sophisticated structure that we have in the body to perceive the motion and movement. So athletes, they really need this approach, and we are working to have a way to assess at the beginning of the season, in the spring training, the athletes, and even if they don't have symptom, treat to restore, optimize the biomechanics, and of course, improve the performance, but even more decrease the possible injury during the season. And we have started this project with some teams in US, and we are now trying to expand in other games.
Mm. I think there's a lot more questions and areas that I'd like to explore, but we might have to leave that for another time, Antonio, because I know you have to get going. But thank you very much for taking up some of your time to speak with us. That was really informative, and it's I think the thing that really stands out about the work that you and what your sister Carla is doing is that the apart from being really contributing to the overall body of literature, but the I think the passion and the innovation that's coming from it, I think is really useful to help try and create new ideas about how we treat musculoskeletal related problems.
Well, thank you for the invitation. Always a pleasure to present our concept, and looking forward to other podcast.
Thank you very much.
You're